Hello, everybody. I hope you hear me well. Today, I'm going to talk about the imaging of infection and inflammation. As I mentioned in the other lecture, we have two major clinical problems related to blood clot and infection. So if we can develop somewhat better techniques or method to diagnose fever in early stage and or some prevention of the infection, just like a blood clot, then will make a significant impact in our clinical medicine. As you see on this slide, there's a big global burden of infection. In 2017, there are more than 8 million deaths related to infection. And that is third in mortality, first in morbidity, morbidity among all human diseases. So that's why it's a big problem. And this slide also showed 36 to $45 billion per year in the United States related to management of the infection. So by 2050, in next about 30 years, the antimicrobial drug-resistant infection will become major cause of death. Well, there are already significant problems related to so-called superbacteria, which is resistant to current antibiotics. I will mention in detail later on, but many gram-negative bacteria become mutated. So they are resistant to current antibiotic treatment. For example, in our intestine, there are more than 20 or 200 billion bacterial cells. They say about more than 250 sort of groups of organisms. They are supposed to be inside the intestinal tract. About 60% are relatively useful, good bacteria. The other 30–40% are bad, harmful. So they are balancing each other in to make a homeostasis in our body. But if we drink so much alcohol, or if we take so much antibiotics, then the homeostasis, the balance between good and bad bacteria will be broken because those alcohol or medications kill the good bacteria. And then those bad bacteria trying to escape from the intestinal tract, and they usually go to the lung with mutation because of different environment. And that's a major problem in many cancer patients, because a cancer patient receive a lot of toxic drugs and or radiation. And their immunity is also very significantly decreased, so that they usually end up dying with the pneumonia in the hospital, but pneumonia cannot be controlled by current antibiotic medication. So that's the common problems at this time. Now this slide also shows tuberculosis is still major cause of infectious diseases because it is worldwide, and the tuberculosis is a still major problem, particularly Mycobacteria become also mutated. So traditional 3 different kinds of antibiotics for tuberculosis are more likely resistant in many such a patient. So that's the problem dealing with the tuberculosis also. COVID-19 is a problem now, but compared with the tuberculosis here, and the COVID-19 is a very small percentage. And as I mentioned, there has been a problem of abused antibiotics by general physicians or many internists. So that's one of sort of a major also problem dealing with this kind of drug-resistant infectious diseases. So in the past maybe 100 years, there are about 10, 15 major viruses or superbugs in the human history. As you see here, Ebola, which was in almost 50 years ago, Ebola, and certainly previously rabies in 1920, Africa, India, but HIV, AIDS were the problem recently, and then certainly smallpox, influenza, particularly Spain influenza in early 1918, killed a lot of patients. And about 20 years ago, SARS were a major problem. And about 10 years ago, MERS were a problem in Saudi Arabia. And this SARS, MERS, combining virus, which is COVID-19, is currently a major infectious problem. Now, as I mentioned, many drug-resistant antibiotic, the bacteria have been recognized, particularly gram-negative Clostridium and Klebsiella, and certain gonorrhea bacteria, and then some tuberculosis and staphylococcus all become changed. E. coli, that's also mutated E. coli, is difficult to control. So there's all the problem, particularly compounded by the devices. As you see here, there have been increasing total knee replacement in the world, and all the hip replacement, knee replacement, all these kind of things are increasing because the people are living longer with arthritic problem. So once you put some foreign body in our body, there is a inflammatory reaction and sometimes infection together. So So early detection of infection is still major challenge. And as I said, economically, this infected all the orthopedic sort of devices make a big economic impact. And dealing with infection or inflammation, we have to understand the pathogens and also the immune responses in the host. And so what we have to know is that you have to know the burden of infection and location, immune response, and some drug penetration or some efficacy. So dealing with all this microbiome, you have bacteria, viruses, fungi, parasite, some this archaea, and this so you have lots of microbiome in the mouth, skins, and the intestinal tract, as I mentioned, and some urogenital system. So they say that we have more than 1 trillion species of microbes on Earth. And in our body, there are more than 100 trillion bacterial cells. That's 100 times more than our body cells, 10 times more than our body. And the known species is about 30 to 50,000. You know, in our human history, there are more than 50,000 known viruses. So bacteria is a small single cellular accumulating substance from environment. That's the exoskeleton, and mechanoenzyme is a definition of this bacteria. And the viruses are smaller than bacteria. From the bits of DNA or RNA escaped from the genes of large organisms. And the there are more than 20 viruses in each of 50,000 vertebrae. And as I mentioned, have been known about 500,000 sort of mammalian or avian origin on Earth. They expect a lot more. This is a lot more than maybe stars in universe. And there are new viruses, 3-4 new viruses per year. And there's more than 200 virus species infect the humans. For example, in the common cold, there are more than 10 different viral species individually. So we are living with all this kind of numerous microbes inside and outside. And so all this document show tremendous numbers of bacterial cells, there are more than human cells. And the reason we have to wash your hands and maybe forearms, there's so many skin bacteria. Here, hands is quite a 29% here. And in the mouth, there are also more than 500 bacteria in the mouth. And every organ system, you have various bacteria, all different kinds of bacteria in our body system. So as I mentioned earlier, we have a good or bad bacteria. Certain lactobacilli is a good bacteria here, but across the region, which is the most common in hospital. So if you stay in hospital, you end up automatically infected by this one. And the function and in the lungs, certain bacteria are defending against some other bacteria, and the certain production of peptide for wound healing, inflammatory control, immune system things. So it's some ironical to have problems, also some protections, just like everything else in our body system. In the brain, some activation of vagus nerve, immune system, and also secretion of neurotransmitter influenced by the bacteria. So it's a good thing. In the gut, as I said, some kind of balancing and makes a homeostasis for the vitamin synthesis. This is important. We are making vitamins in the guts. So if you have a good homeostasis, that synthesis is working, but if you have such an unbalance, then you end up having vitamin deficiency. And then certain metabolic process of carcinogens. So that's important also. So we need there's a kind of homeostasis of bacteria in our gut, intestinal tract. And so skin has lots of bacteria, as you see on this slide. That's why you have to wash your hand, forearm. There's lots of bacteria. And the viral infection also in every organ system, brain encephalitis, meningitis, all different kinds of viruses. And common cold is a rhinovirus or thing. And then pharyngitis, in the cardiovascular, Coxsackie virus, in fact, hepatitis, virus, A, B, C, D, E, lots of different kinds of virus in the skin, eyes, also herpes, eyes often, pneumonia, influenza virus, pneumonia in lungs, then SARS, so myelitis also, and gastroenteritis, they know all the things. Pancreatitis, also Coxsackie B virus. So every organ system can be infected by the virus. So COVID virus, as I mentioned earlier, is known of a combination of 20 years SARS and MERS 10 years combining, has a very spikes in the membrane. This is apparently very important in developing certain drug, antiviral drug, to penetrate this cell through the spikes. So there's envelope here and spikes over here, and then genome here, some enzymes in the cells. So there's a spike protein is a major target for the sort of development of drug. and sort of usually in a bat in originally Africa or China host this virus. But if we destroy the nature, bat cannot live in the certain places like Africa or China things. And this virus has to leave for other areas and then trying to be survived. So this sort of MERS or SARS and this all passed, but they are still around some place. All this virus cannot be completely eradicated. All the viruses known has been sort of subsided, but they remain still alive in some place. And these two viruses genetically combining together and makes COVID-19, which is currently infecting and killing a lot of patients in the world. So again, this kind of combination and much more infectious or violent. And so there are some stages of this early and some pulmonary phase and hyperinflammatory phase. During this phase, there's some certain asymptom and some pulmonary symptom and general symptoms, all this clinical. And in the therapy, initially just immune suppression, and later on maybe steroid, and then certain antiviral sort of inhibition. And the interesting thing is that this virus also makes a thromboinflammation. And so it's in effect endothelium makes some microthrombosis. And so this produces acute respiratory distress syndrome, hypoxia because blocking capillaries, there's no oxygen exchange. And obviously it's a macrothrombosis makes a arterial or venous thrombosis. So hypoxia is also produced, that triggering a lot of diseases, as I mentioned in the other lectures. So this viral sequences has shown some kind of overlapping human certain RNA, DNA, and gene. It's all, there are some unique genes, but there's some combining together. And this is a new highly pathogenic human strain. Is sort of a combination of certain avian strain and human strain together with this, or as I mentioned, some kind of spikes to protect themselves. So in the diagnosis, in the beginning, the PCR makes a quick diagnosis because viral RNA antigens are spiking. And then later some immunoglobulin starting. And so initially PCR, later immunoassay can show this kind of antibodies. So same thing, in the early, the symptom may starting, and then PCR is likely positive. And later when the antibody detected, the PCR may be negative. So PCR is a quick diagnostic thing from swab, nasopharyngeal usually swab. But later blood tests showing immunoglobulin antibodies. So you have to actually have this kind of test based on the timing of the symptoms. But if there's no symptom all the way, you may have to have a both PCR as well as antibody detection. So virus enters cells, our body, and release an RNA, and this RNA invades our body cells and use a host cell to create a new RNA, and then more viral particles. And these new viral particles release and destroying the other cell. So it's a continuous cycling. So we have to block this entering of this virus into our human body cells. So entering is important. So that's why this entering is influenced by angiotensin converting enzyme. We talk about this enzyme more often in the renal system. I'm going to give you a talk on renal failure next week. But somehow this enzyme works also in this entry of this virus into our cells. So we have to block this entries. And once this comes in, and the viral RNA and make a protein, and there's all kind of cytokine and immune cells positively, negatively working in balance series. Particularly this a transmembrane serine protease. This is also important together with this angiotensin converting enzyme. So current research trying to manipulate this two sort of enzymes. The protease generally melt certain cellular membrane and penetrating things. So inhibition of this one, or this converting enzyme inhibition is sort of ways to maybe treat this virus. And again, ACE enzyme and the transmembrane protease, these are important in endocytosis of COVID virus here. So a lot of research work on this two enzymes at this time to control this one. Again, a viral infection, once they infect, a lot of immune cells are working, and because it destroys immune system, and so certain macrophages, cytokine storm, too much, too little, or is a problem. It has to be optimized in certain environments. Excessive production of all this immune cells or cytokine cause dysfunction of immune system. And so that will make a pulmonary edema, pneumonia, and multi-organ damage. And therapeutic approach, we have to try to block the binding this angiotensin converting enzymes. Okay. And in certain protease inhibitor, we have to use the transmembrane protease. And thirdly, this excessive sort of T cell effector cell. This has to be maybe this will kill some infected cells, so this has to be enhanced by some ways. And certainly the cytokine, excessive cytokine production has to be neutralized through the certain blocking antibodies or something. And then certain pro-inflammatory cytokine has to be blocked. So again, similar things is a lot of companies are trying to utilize the plasma antibodies or antiviral drugs. Remdesivir, which is probably the most, that drug was used in other viral infections, but this also works in some of the patients, not all the patients, some. So President Trump received remdesivir. Yes. But as I mentioned, initial blockage of this angiotensin converting enzyme, transmembrane protease, that's the first thing. And then certain this antiviral drug block certain this proteolysis. So this viral comes in, entry, that's the first step. And then translation, that's RNA to make a protein has to be black or thing. So replication has to be blocked by, but no single method has been totally successful. Well, that's why it's a theory, it's so clear cut, but even you block the entry things, it's not working completely. So just like cancer, it may have to combining all the processes, but that will certainly make quite a toxicity. And certain immune therapy has been proposed, certainly, because this dysfunctioning immune system by virus has to be controlled, so that if we optimize immune cells, that's another way. The chloroquine or hydroxychloroquine, Trump has been initially advertising this one. The mechanism is still unclear, nobody knows how, but it works in some patients as antiviral activity. So no one seems to know clearly, but during all this process, entry and some translation process and then replication, there's a chloroquine block in some steps we don't know yet, but some works. So antibody has been proposed, a lot of sort of antibody against certain this kind of blocking receptors or things, membrane fusion things. So we don't know. And then a lot of people expect to see some vaccines. Vaccines have been used for all kind of infectious diseases. If we use a live virus, then we expect to have much more efficient maybe antibodies developed. But in some patients, that's a very risky. A lot of sick, weak patients, in fact, develop viral infections with vaccines. That's the dilemma. And then certain virus like protein, messenger RNA, polysaccharide, other all things, or inactivated bacteria. Certainly it's safer than live virus, but it's not efficient. The antibodies are generally weak, so that's a trade-off. So, and also many viruses known to cause cancer, we know, or many cancers are related to human papillary virus and cervical cancer, Epstein virus, head and neck cancer, and all the hepatitis B, C thing, all. So hepatoma. And there's called bacterial phase. So there's certain bacteria can be killed by this bacterial phage. So some viruses infect bacteria. So antibiotic-resistant bacteria has been tested by this phage therapy using viruses and show some usefulness. And so as many new approaches have been proposed, mostly related to immune therapy, But as I said, there are so many immune cells, immune cells function are also very variable depending on the microenvironment. And it has to be a certain optimized balance situation. If too much, too little makes all problems. And so there's a new sort of aminoglycoside antibiotics has been reported, and the protein degradation and then affecting all the cellular TCA cycle metabolic process. And that's one of and then in the colorectal cancer, 13% show the positive PCR on this very unusual bacteria, Fusobacterium nucleatum. This makes a shorter survival because this makes microsatellite instability. Microsatellite is less than 9 or sometimes 6 DNA. And so this will make a anti-tumor immunity suppression. So, and also certain E. coli carries certain enzymes, and this also linked to colorectal carcinogenesis. So about 10% colorectal cancer shows this kind of enterotoxic E. coli. And with this enzyme, polypeptide synthase. So vaccine is a very dramatic sort of a medical intervention in the history and prevent a lot of diseases. However, okay, this, as I mentioned, it could be active component using virus, bacteria, toxin, or adjuvant certain, and antibiotics and other things. So a lot of questions is about the effectiveness or risk things. And as you know, Pasteur used first certain attenuated organism for rabies, and this calmette-garin for Microbacterium. And it's very successful in smallpox, polio, measles. However, there's quite a risk, as I mentioned, in 1955, using Salk polio vaccine. That's a live vaccine. And then 40,000 children actually developed the polio. So that's a serious risk problem. And measles also is useful for many, but there was some kind of side effects with atypical measles, pneumonia, peripheral, etc. So it's a lot of, so we need we need good vaccines for all this kind of HIV, COVID, certain fungi, parasites, but somehow vaccines has not been successful in influenza virus, malaria, tuberculosis. So it's now a lot of companies are trying to make a vaccine, and we don't know when they be available, but there are also some pessimistic opinion because of this virus continuously changing, evolving biologically every day. So a lot of subtypes will be developed. Then certain vaccine medication fitting to certain type may be useful, but others are useless. And so it's a lot of DNA vaccine, RNA vaccine. There's all advantage, disadvantage. Certain DNA virus is less immunogenic, easy to develop, but no DNA vaccines has been licensed, but we don't know the effectiveness. Messenger RNA also cheap, but degradation is a major problem. The antibody responses are still questioning. We don't know. So now we have to talk about the imaging. Now, importance of imaging is to look at the whole body again, and then localize certain infectious or inflammatory source, and then we can estimate certain burden of infection by looking whole body system. So it's a very helpful but anatomical study basically show organized abnormality like abscess things. And the massive certain inflammatory reaction can be also shown, myositis, pancreatitis, but all the findings are not specific. Furthermore, inflammation or inflammatory reaction cannot be separated from infection, and also cancer. Cancer with without therapy often become associated with inflammation or inflammatory reaction. So infection is basically related to microorganisms, but it often associated with also inflammation. So to separate, you have to utilize microorganisms, or in the inflammation is a multifactorial response, tissue response, particularly immune response. So if you utilize immune system, then you might find more inflammation or inflammatory reactions. Now, this inflammation can be caused by trauma, certain foreign body, certain stroke type ischemia and tumor, and it involves immune cells or lots of chemical mediator, chemokine or cytokine and protein. So all anatomical study cannot separate infection, inflammation, or inflammatory reaction, or cancer. So all nuclear medicine, most imagings also have the same problem, because the fundamental pathogenesis are very similar together. Only difference, inflammatory response by certain cytokine. Okay, it shows some increased blood flow, but increased blood flow can be observed in infection, inflammation, or cancer, all mixed up. And so combining certain specific imaging, looking at the microorganism, and then looking at the immune response by certain radio-labeled immune cells for inflammation or inflammatory reaction, may be able to separate. Now, this abscess is a pus pocket collection, mostly neutrophils in response of infection. So usually acute infection has lots of neutrophils. Chronic infection, usually monocyte lymphocytes. So I'll mention later some more detail with other agents. Now, fever unknown origin is a clinical problem. The definition is 3 weeks of illness with fever, or 3 days hospitalization with greater than 38.3 degrees centigrade or 101 degree Fahrenheit. That's the definition of FUO. There are many patients with FUO in any hospital. 10–15% of those patients will never be diagnosed for the cause of the febrile illness. So clinicians try to find the source, but usually just treat with antibiotics if they respond, and then okay. But many are having chronic, just a mild inflammatory disease without knowing the cause. Particularly in cancer patients, cancers also produce pan-neoplastic syndrome, which includes some kind of mild fever. That's a tissue reaction. So that's another major clinical problem. So we have to look at 2 processes, pathogens, okay, particularly Staphylococcus, which makes usually abscess, cavitary lesions, so that kind of thing. And then all kind of immune cells are working for the reaction together. And the CD4 T cell is a sort of a helper cell, inducing cell. CD8 is a killer cell, killing pathogens or other things. Okay, and so a dendritic cell is another immune cells, and then NK cell doesn't usually, well, it's a very small proportion. And So in the early or acute, there's lots of neutrophils. Later, monocyte, lymphocyte, including T cells, B cells. So in the response of infection, bacteria comes in, and then there's some kind of peptide formed, and then we have a phagocytosis killing process, and then T cells were recruited to fight against it. Liposaccharide protein in the macrophage also works. And then there's a process of chemotaxis occurs. And then later, or this granulocytes initially stuff, and then later monocyte, lymphocyte. So this altered homeostasis is sort of a changing by age. When you are getting old, there's a less integrity of blood vessel. Elasticity is decreased in the blood vessel. So response to injury is also decreased. So they often develop amyloid angiopathy. Now, platelet function is slower in old patient. The platelet is also relatively less sticky. So they have easier bleeding. If they have a trauma injury, they can have a lot more quick bleeding, and particularly brain hemorrhage. This thromboplastin also released, enhanced with age. And the thrombin also increased. And the factor 9, 10, fibrinogen also increased with age. D-dimer inflammatory markers also increase normally with age. So this, when you are dealing with the pulmonary emboli, false positive D-dimer, you have to check with age. So there's some altered vascular homeostasis by aging. So this inflammation, as I mentioned earlier, is caused by many cardiovascular, chronic lung disease, inflammatory bowel disease, diabetes, cancer, and also vice versa, inflammatory reaction triggering developing these diseases. And so, Helicobacter pylori relate to stomach cancer. Herpes virus is a human papillary virus. It's a cervical cancer, hepatitis B, C, hepatoma, Epstein virus, head and neck, squamous cell cancer, and the Kaposi sarcoma also relate to human virus. And then also too much cytokine relate to, anorexia, fatigueness, depression, by usually this interleukin-6, tumor necrosis factor, alpha, and then certain toxic effect, pituitary gonadotropin, and that will make a proliferation of ovarian epithelial cancer. Now, I probably talked to you about the inflammatory breast cancer. That's a unique problem, which is really bad in prognosis. So acute versus chronic inflammation is related to immunity. The adaptive immunity is related to antigen. antigen, and so it will make antibody production. Innate non-antigen stimulus. So helper cell, immune helper T4 usually works in this acute inflammation. Chronic is so it's continuously ongoing together. After certain bacterial comes in or injury, there's an inflammatory process and there's a healing process. During these processes, you can see lots of immune cells, a lot of sort of factors are working. Even in the blood vessel, there's a lot of vascular permeability, adhesion with this cellular function plate environment. Makes also certain fibroblast, makes a collagen sort of a wall of membrane things. So this fibroblast has been recently emphasized in developing cancer and also diagnosing cancer, even maybe treatment cancer. We have to. So in acute inflammation, you have a certain allergic reaction, chemical, all kind of potential causes. And then this will slowly leads to chronic conditions. This chronic inflammatory reaction or disease triggering all kind of diseases. So that's a problem, including cancer, but all kind of disease we know is related to inflammatory processes. So that's why it's controlling inflammation is critically important in our every disease we know. And so in a chronic inflammation, including even depression, Alzheimer, Parkinson, all that unknown diseases has been also reported to be related to inflammatory. So, we have to study more and more this chronic inflammation. But biologically or this histologically, the wound healing versus tumor growth are very similar, very similar. So that's why by imaging, it's not easy to separate tumor from wound healing or inflammation. This wound healing is basically inflammatory process, reactions, very similar. And the chronic inflammation here initiate and promote, and then generate a certain tissue destruction, and then even invasion, metastasis, and so this will trigger to cellular transformation, namely cancers. So that's so it's inflammation, tumorigenesis, shared all kind of antigen, mutation, genomic, all this thing sharing. So if we control inflammation, we may control also tumors. So this, and also, this, if we use chemotherapy induces inflammation. This inflammation triggering cancer growth. So that's a dilemma, all therapy basically makes a chronic inflammatory reaction. Radiation, particular radiation also. So how we deal with this kind of dilemma, that's it's always a difficulty, and it has to be related to immunity. So we have to sort of balancing, controlling immune system. So again, there's many immune cells are working for anti-tumor process as well as a tumor promotion. So it's both ways. So too much, too little makes all two different directions. So it's all macrophages, particularly nowadays M1, there are two types, M1, M2. It's the opposite function, okay? And the dendritic cell, other cell, B cell, CD8 is a killer cell, but even killer cells, all T cells are regulated by T regulatory cells. And too much, too little, all problem. Natural killer cell has a direct cytotoxicity, good, rarely promoting tumor, but it's only 5-6% of total immune cells, so very small. So there is now new technique, sort of mechanically increase this cell numbers. So that has a new sort of approach. So natural killer cell therapy has become recently emphasized because of that new technique to make more NK cells in vitro at least, and then reintroduce after. So that's what we have to see. But the common T cell or B cell macrophage has both opposite immunosuppression versus this sort of anti-tumor by producing cytokine. So cytokine, chemokine, it has to be also balanced. As I said, too little, too much, or makes a difference. And too much inflammation, and then make a tumor growth. And then too little makes a restricted tumor growth. And so alter the balance also in some way makes a tumor regression. So this kind of ambivalent, bidirectional, all the same cells are not easy. And these are also variable individual. The balance is variable. And so that's why it's not easy to manage individual patient because of this two different opposite sort of functional aspects. For example, also this breast cancer metastasis. And the cancer started, but all this immune sort of a microenvironment, inflammatory, angiogenetic, lymphoangiogenesis, makes cancer. And this cancer produces this sort of inflammatory marker. So we can block that thing to prevent further metastasis. So in the bone, they go to often bone, liver, lung metastasis by using this certain cytokines. So if we block, that's helpful. So the chronic inflammation also cause heart failure, cardiac failure. So that's the important things. If inflammatory occurs in epicardial fat, that will accelerate atherosclerosis, atrial dysfunction, and produce arrhythmia, and eventually heart failure. So ejection fraction will be decreased. So there's also autoimmune disease. You hear in too much. There's T regulatory cells, T cells, killed, damage their own cells. So there's a lot of autoimmune disease based on this unbalanced, unaltered this immune cells, like rheumatoid arthritis, many other those things all cause. So all this cytokine, these things comes in and stimulating NF-kappa B, this major gene stimulating either inflammation or cancer, this also cancer. So Celebrex, that's the drug available, was made from the aspirin, Celebrex, that inhibit NF-kappa B, so that Celebrex is currently best drug for arthritic pain and also prevention of infection, inflammation, and also cancer. So at MD Anderson, we usually give Celebrex for any patient with colorectal cancer, because colorectal cancer has been also related to aspirin, and the Celebrex is very, very good drug. And this, so this autoinflammation is always. So again, multiple cytokine cells are involved in inflammation or even cancer. So skin can be ulcerated, redness, and edema, all things, but underlying subcutaneous, all this different immune cells are trying to balance in healing process, but too much, too little makes all abnormal symptom, signs, or progression of other diseases. So going back to fever unknown origin, it's a very common clinical problem. There are many, many causes. In adults, mostly certain infection, bacterial or viral infection. But about same instance is cancer, underlying cancer. So you, in dealing with the fever unknown origin, you always have to check any possible cancer. So that's why we need the whole body images. Particularly in the United States, we use PET scan using FDG. But the other is autoimmune disease. A lot of unknown autoimmune disease, polyarthritis, granulomatous disease. In children, majority are still with a bacterial or viral infection. A small percentage are cancer and autoimmune disease. So for the infection, still worldwide, the TB is most common. In adults, endocarditis, some certain Africa, other countries, HIV/AIDS, and certain hidden abscess, particularly abdominal liver abscess, brain abscess, and cholecystitis is also common. Cholecystitis, cholangitis, osteomyelitis, urinary tract infection, gum disease, gingivitis, sinusitis, and certain fungus infection, and cytomegalovirus infection in cancer patients, immune suppressed, So fungus and this kind of cytomegalovirus are common in cancer patients. And in the cancer, we have to think about lymphoma. Lymphoma patients often present with fever, leukemia, certain Castleman's nodal hyperplastic lymphadenopathy. Renal cell also is causing fever. And then atrial myxoma, benign, most common cardiac tumor is myxoma. Certain hepatic tumors, hepatomas also produce fever. Now also autoimmune disease, all kind of arthritis, lupus, and cryoglobulinemia, polyarthritis nodosa, polymyalgia, all kind of autoimmune disease. Other things you also have to consider, thyroiditis, which is very common thyroiditis, sarcoid in the United States, and certain Whipper's multi-system disease, pulmonary emboli, hepatitis, and certain drug can cause also fever. So there are so many causes make a fever unknown origin. So about 10–20% will never be known. And so you have to exclude all this, particularly cancer and certain underlying infection. And then everything else is more likely autoimmune disease. So we have now quite a serum markers of autoimmune disease. So you can check usually for cancer, FDG PET scan whole body, for infection, SED rate, and then certain some infectious markers, and then this rheumatoid, etc. Those have some markers we check. Thyroiditis is usually just antibodies. So it's one of all the case because of this myocardial activity. And if you see brain, that's FTG. If you see only just myocardium, you can think about sestamibie and thallium, that kind of thing. Now here we have a focal increased activity in the mediastinum that was proven to be small abscess, unexpected. So here all this reported a few studies by FDG. So, but as you see here, positive predictive value is very high, but somewhat sometimes not good. But if you see something, that's more useful. But if you don't see, still not excluding certain unknown diseases. So lung is like a filter of our body system. So all the major cancers eventually go to the lung. And once the lung involved, then they spread to other organs like liver, bone, etc. And so whenever we breathe or the certain injection things, it all end up in a lung capillary, like a pulmonary emboli. So bronchitis, inflammation of bronchial trees. So lung cancer, bronchial adenocarcinoma arise from the bronchial gland. Okay. And certain inflammation in the air sacs, the alveoli, as pneumonia, is blocking sort of air exchange. And then the chronic or the lung disease will make eventually damage and make a scar, fibrotic lung tissue. So there's coronavirus comes through the breathing or even touching something and invading skin, and then comes into this sort of a respiratory tract, and then proliferating and makes pneumonia. So we see mostly pneumonic infiltration on corona. And then it's a chronic airway infection. We have lots of bacteria in the mouth. You can swallow and goes in the stomach or GI, but when you breathe, it goes into airway system, and the strep, that's the most common. And then sort of a Pseudomonas are the gram-negative, all this common bacteria in the lungs. This year, World Molecular Imaging Society surveyed, and then 86% showed the interest in research of infectious disease. So that's a good thing. And then 52% were planning to write a grant for research of COVID-19 virus. So there's quite a people are interested in infection now, particularly with the coronavirus impact. So how we image infection, how we improve diagnosis of infection, and that has to be related to pathogen-specific imaging. So how do we really understand the pathogenesis? Not yet. So we have to image immune system, immune response. So can we optimize antimicrobial antibiotic treatment? We don't know. Some people only 10 days, some 2 weeks. We don't know which one is that. If we overuse, that's a problem. So less is a problem. It's how we optimize. And so we like to have radio-labeled antibiotics for optimal sort of a biodistribution, and then pharmacokinetics, pharmacodynamics. That the information will provide probably a better idea about optimizing antibiotic treatment. Okay, oh my gosh. Let's have a 5-minute maybe break. If somebody wants to go restroom or some drink water, it's okay. I will restart in 5 minutes. Again, if you have any questions, comment, or whatever, you write down on the evaluation paper. And then there was some suggestion for me to give some cardiac or cardiovascular imaging, but I understand the Professor Lee gave you talk on cardiac imaging. So maybe we'll do next year, or if there's some extra time, I may give you that topic. But at this time, we'll just try to give you some important clinical topics. I originally planned to give you a talk on tumor, immunology, metabolism, or genetics. those still more research. So I will hold on maybe for next year or sometime. Okay, so why don't we have a 5-minute break? All right, I will continue to talk about, as I mentioned, imaging is important to make a diagnosis and also monitoring disease progression. And certainly we'll understand better pathogenesis of infection or inflammation. And therefore, we'll optimize management or treatment of the patient. By utilizing certain molecular imaging, which is obviously non-invasive, and more sort of accurate, using a specific certain bacterial imaging or certain metabolites of the pathogens. So ideal PET tracer, as you know, has to be highly specific, sensitive, quantitative, and also it's a rapid. Imaging is important, and obviously safety issue. And so this infection-specific PET imaging is certainly theoretically useful in determining certain the pathogen and response of therapy and certain burden of infection and the so in earlier this year, JNM published the role of nuclear medicine for the COVID-19. So detection of inflammatory process with FDG in patient with COVID-19. And then research by generating biomarker for the certain drug, and also important thing is fibrotic process after infection, utilizing fibroblast activated peptide. So that's very important for evaluating patient. And in certain, as I mentioned earlier, therapy inhibiting angiotensin converting enzyme or transmembrane protease, those are the important in research. So molecular imaging research for the coronavirus has been related to imaging virus reservoir. Reservoir means a site, location, the inflammation at the whole body system, and then post-inflammatory fibrotic system, and then drug pharmacodynamics, pharmacokinetics, and certain vaccine evaluation, where they go, how much they stay in the certain body system, and immune cell activation. So this is an example of neuroinflammation. Stroke induce some kind of damage and then make a neuroinflammation. And so this also show some stroke makes a certain reduce like heart failure, as I mentioned earlier, and also inflammatory marker that's a transmembrane, this a TSPO marker, that's a neuroinflammatory marker that's also elevated in the heart. So it's all brain, heart, all organ systems are affecting. This imaging shows a classical findings of abscess, brain abscess, by the superbug, that's a antibiotic resistant, either gram-negative Klebsiella or E. coli, I think. surrounded pocket edema on T2, and then post-contrast show enhanced wall, so, and necrosis in the center on the sagittal, and the diffusion imaging shows high signals, and then the APC map shows opposite signals of decrease. ADC map show. And this enhancement is a sort of vasculitis. It's a linear sort of periventricular enhancement. Some sort of vague, hazy, sort of increased signals on this diffusion imaging. This map showed opposite sort of decrease. This all indicating a restriction of diffusion. Macromolecular water movement is restricted. So these are encephalopathy, but this encephalopathy could be related to virus, bacteria, or even sarcoid, or autoimmune. And they cannot separate which one is. And also, it could be related to just non-specific vasculitis. So imaging show anatomical sort of results of inflammatory or infectious processes, but they cannot pinpoint the cause. And then this same thing, encephalopathy or vasculitis can be involved in the spinal cord. It's an enhanced spinal cord here. It should be a little dark. Yeah, so, and you can see enhanced all this spinal cord. And then a COVID case reported. It's all just inflammation is diffuse out, so more likely hazy, increase the signals diffusely here. Yeah, and here, yeah. And lung, so-called ground glass appearance is a haziness, alveolar. Alveolar need air exchange, so it should be dark. But if there's a inflammation or infection, it blocks air exchange. So it's either edema or whatever, and it shows this kind of ground glass appearance, haziness, alveolar densities, and mostly periphery. Yeah, yeah. That's a typical finding of alveolitis. And the bacterial infection often make we call consolidation. It's sometimes collapse the lung, collapsation, surrounding bronchi or pulmonary vessels. So this is a bronchogram. Means this is all pneumonia, alveolar pneumonia. And then certainly makes abscess necrosis surrounded by all fluid things, a fluid level by necrotic process. This is a superbacterial pneumonia. It's non-specific finding. And in the liver or abscess, a large pus pocket surround. So all multiple abscesses by superbacterial infection. Pancreas here, and some small sort of a low density, could be small necrosis. It is more likely pancreatitis makes edematous, swollen pancreas. And some may be surrounding small lymph node, but it's more likely small necrosis. With haziness, usually we see some little lobulation, normal, fatty density we don't see because of edema or thing. Yeah, so this is dilatation of pancreatic duct because it's obstructing proximal portion. Pancreatic duct is all, and has this is the head of pancreas makes it all swollen. It's almost like a pseudo tumor obstructing here, but this is a chronic pancreatitis. by this imaging, you cannot rule out certain tumor blocking here, small tumor. And then other bowel enhanced, there's also some bacterial mucosal inflammation, edematous mesentery, and then or some fluid. And the diverticulitis is a common problem, particularly in patients with the constipation. This diverticulum occur, and the feces accumulate in diverticulum and makes a diverticulitis that can be ruptured, and this mesenteric fat become so-called dirty, and due to inflammatory reactions. This fat density should be black. It's a haziness here because of edema or infiltration of inflammatory cells or tumors, and all this surrounding bowel wall is this peritoneum, mesentery, all this inflammation. And certainly air is abscesses, and the iliopsoas muscle here, abscess occurs here, all bacteria. You know, ultrasound, the salmonella infection, here also ultrasound report in the literature. And so in the infection, you have to rapidly localize, and this uptake should be proportional to the infection. The labeling should be simple, that's ideal. So leukocyte has been labeled with technetium and indium. Indium-111 has been most widely used. And glucose, FDG, has been used because FDG attached to the macrophage, which is in more likely active chronic infection. Certainly anti-granulocyte, neutrophil, has been labeled with technetium, and the cytokine has been labeled, and certain inflammatory marker like E-selectin has been labeled with technetium. So technetium indiums are ideal for gamma camera imaging, and gallium-67 was quite used when I was in junior faculty, and but has a wide range of energy, but the longer half-life. And so, but gallium-67 citrate has been mostly useful for chronic infection. Indium-111 or technetium leukocyte has been used mostly for acute, and it's optimal energy for gamma camera, and the short half-life relatively. And so, okay, I have to move on. And then some specific infection imaging is related to leukocyte. Leukocyte is, as I said, it's direct labeling, and since neutrophil is usually that's abundant in acute infection, this has been mostly useful for acute infection. Certainly antibody antigen interaction utilizing anti-granulocyte antibody. But this takes more time, more expensive, so it's not been successful. Other cytokine has been labeled, but it's not been also used much in clinical routine practice. Inflammatory marker, as I said, E-selectin antibody has been also tested, but not been used much. And the microorganism labeled Cipro, commonly used antibiotics, radiolabeled the ciprofloxacin has been tested. And then most widely used is FTG pad, because this easily available now, is popular for cancer imaging, etc. So specific agent utilizing metabolite. This nucleoside and then sugar, this kind of cellular wall, and the certain ion transferring things, and the peptide, ubiquitin. This has been all labeled. Certain drug, antibiotics, antifolate, particularly ciprofloxacin, and then indium 111 oxin, and technetium HMP or labeling white cell, and then a certain bacteria and the bacterial fads. That's was reported, and then certain vitamins, vitamin 7 and 12, other certain prothrombin, lipids, that has been all. And here, okay, F8 and FDG for metabolic process, MR spectroscopy also, and then cathepsin, just like a tumor imaging. Immune cells also has been utilized. Hypoxia agent has been also used. It's not specific, but this also is important to trigger progression of disease. Apoptosis has been labeled using F18 or technetium labeled anaxin 5. It's not here, anaxin 5. And certain MR imaging also used for lung function. Mechanisms are totally unclear, but we know gallium-67 citrate is bind to the transferrin. That because of that, any area of sort of a increased blood flow will show increased uptake, but this also attached to certain, inflammatory cells and some inflammatory sort of immune cells. It's a lot of immunoglobulin has been labeled, and some antibodies, anti-granulocyte antibodies. And they based on certain hyperemia, vasodilatation, certain all this cell labeling also show uptake, non-specific. And as I said, macrophage takes up FDG for metabolic trapping. Receptor binding interleukin 2 or 8 has been tested. And certain, as I said, the antibiotic directly hit the certain bacteria. Ciprofloxacin has been. And then it's all optimal energy indium. This is a little, but multi-channel analyzer combining 100, 200, 300 kb gamma rays, gallium. So imagings are very good. There's a gallium-67 citrate attached to transferrin, and then this, and it's similar to glucose, as you know, glucose transporter and hexokinase phosphorylase, and then it generates lactate. So the tissue makes acidity, and it's similar. There's gallium-67 transferrin attached, and then there's also somewhat related to lactate formation. And so this, I don't have to. And so basically gallium citrate has been used more likely for chronic infection, particularly sarcoid, pulmonary fibrosis, and some certain pneumocystis carinii pneumonia in cancer patients, and that kind of things. But nowadays, this supply, gallium-67 citrate supply has been very difficult in many countries. I don't know why, because we don't use that much because of F18, FTG. So all the scan, but this is a normal distribution of gallium-67 citrate. That's normally lacrimal gland shows increased uptake. So uveitis will show a lot more intensity. breast, lactating breast, liver, but nothing else. And certainly fracture will also show all the fracture, non-specific. Certainly inflammatory osteomyelitis will show, but the linear osteomyelitis generally show infiltrative, so it's a diffuse, not the focal. And this old slide show a very intense increased activity in this right side sort of inner ear otitis. It's a show, it's proven case. And this so-called lambda sign, lambda in sarcoid, the perihilar lymph node takes up blood, it's gallium citrate. So it's called lambda. Panda is a sarcoid uveitis, very intense eye, much more than normal lacrimal. So this is a panda sign for sarcoid. Certainly parotid submandibular gland, normal physiology. And this hilum is like a very intense. That's the characteristic, but the hilar, that's a sarcoid. And certainly pneumocystis carinii pneumonia in cancer patient showed diffusely increased activity here. Yeah, it's a bleomycin toxicity, usually show same thing, bleomycin toxicity, chemotoxicity. Why the mechanism is unclear, but this. And so this long activity is related to a lot of drugs, this methotrexate, bleomycins are most common. So this using all this kind of different agents, sensitivity all similar around the 80, 90 specific around, very good. And the indium oxin label versus technetium, this is more stable. Indium labeling is more stable. It's not stable, but it's cheaper, quicker. That's it. And so here, so indium, we have 4 hour to 24 hour. Just the intensely increased activity in the spleen. That's indicating labeled cells, either white cell, red cell, platelet, all show. But red cell platelet show cardiac pool or aorta or vena cava major, but leukocyte show nothing. If you see there's a heart, spleen, and kidney, that's a neuroendocrine tumor, somatostatin receptor agent. But if you don't see here, that's a leukocyte, nothing else. No bladder, nothing. That's a normal. So if you see something else, that's abnormal. That's some ill-defined increased curvilinear ascending colonic is ulcerative colitis. So ulcerative colitis, that's leaking of these cells into intestinal lumen. That's why you see here. If you see something in the bladder, that's cystitis, or bleeding. So all the sensitive specific, greater than 80 is useful clinically. Less than 80 is not useless. So that's this is another sort of leukocyte scan with heart, spleen, nothing else, but the curvilinear small bowel, that's a Crohn's disease. That's also leaking of leukocytes. So in England, other countries, this leukocyte imaging has been used to monitor patients with chronic Crohn's disease or ulcerative colitis after treatment. And so this nowadays, the SPECT CT is much more useful to localize precisely the abnormality and characterize the abnormality and detection of additional small lesion on CT or MRI as increased activity in the hilar, perihilar. And then SPECT show also retroperitoneal lesions. So it's something, and then post-operative wound still show that's an infected wound. Show this. So hepatic abscess on transaxial is a very focal, intense. This is relatively acute because of neutrophil, and then some peritonitis diffuse and some multiple things. It's peritonitis. And this splenomegaly intense. This technetium labeled. And so there's a little bit here. There's a small abscess here in the this liver, so behind the posterior. So it's a small abscess, and then you can see pus pocket here in the posterior in the liver, segment number probably 7. Yeah. In pediatric bone scan, and then it's not, you have to look at all growing epiphysis for any asymmetry. There's a little asymmetry here. This calcaneus is a lot more than here, but there's a positioning things, but anterior, posterior all show this. And it shows SPEC is a much easier to increase activity. And then this was osteomyelitis, and then leukocytes. Yeah, certainly because of a hot spleen, if they remove the spleen and we can see something that's called splenule. So they spill the splenic tissue during the surgery, and then the splenic tissue grow up. And so as on CT/MRI, it looks like a tumor metastasis, but this was actually sprenules. And certainly transplanted kidney in rejection also takes up leukocyte. So in rejection, there's a leakage of all these cells. Okay, that's actual rejection. It's a vascular problem. Acute, maybe tubular necrosis show also together. But anyway, there's a uptake. It's either infection or a functional problem, ATN or necrosis. So the technetium label, you have a serial images, and the initially you have some lung, diffuse lung test, and 24-hour you clear. And then later you have some bowel activity. And then if you see the stomach or thyroid, that's a so-called free texture, unlabeled, or labeling was not stable things. But if you don't see that's is a colitis, can be suggested. Okay, so for FTG PET, any chronic osteomyelitis, complicated diabetic foot, and certain infected prosthesis, FUO, AIDS, graft infection, fistula has been indicated. So this FTG advantage is early imaging, very high resolution. Single scan whole thing, but the cost is a problem. And the confusion with tumor infection, that's a major problem. And tuberculosis also show, it's just like a tumor. And the mediastinal lesion has been just like a tumor. In Korea, some other countries, we still see very intensely increased activity in the tuberculosis, adenopathy things, just like a cancer. So in cancer patient, you should be very careful without knowing the clinical history. And so in the lung apex also show this is a tuberculosis rather than lung cancer, apical tumor. FTG uptake is totally non-specific. We have to understand the pharmacokinetic. Rifampin is another now drug for TB, other things. And the other drug works in mycotic inflammation, and then it's rifampin directly inhibit this RNA replication. And so this enzyme, so-called LIFMO, is important in converting these things. So labeled rifampin with the C11 has been reported showing TB meningitis. This meninges takes up. But I think FTG also show. So this is again more specific because they label the drug. So how much drug accumulated in the known area, and then you can follow up how much. That's advantage. And certainly pneumonia is very non-specific finding here, patchy, and then takes a FTG macrophage. It's chronic infection more likely. HIV drug has been labeled, or there's inhibitors of enzyme basically. Right? And then it shows uptakes, but not much. So now it's a COVID FTG also show. So you know this CT show all this classical ground glass densities. And how much FTG is helpful, we don't know. Yeah, but vasculitis. So anything curvilinear is not generally related to tumor or abscess. This linear things you have to consider certain vasculitis on FTG, because FTG accumulates in macrophage in atherosclerotic vessels. So this atherosclerotic inflammatory things, again, macrophage is a main region. So this PK10195, this has been used more neuroinflammation, attached here and the things. And yes, lupus, also systemic vasculitis, showing some non-specific findings, and then FTG also takes up this chronic sort of autoimmune disease, hepatic abscess, takes up. In the liver, there's lots of phosphatase, which reverse hexokinase 2. So many hepatomas show just a minimal uptake of FTG. But if abscess doesn't have much phosphatase, it will show this intensely increased uptake. So renal infected renal hepatic cyst also show. It's sort of you can see wall of cyst. And then in the polycystic kidneys, and some also is a lot of hepatic cyst. Some are infected, showing this kind of FTG uptake. Some are not. Certainly non-specific agent can show fungal granuloma, also show mediastinal lymph node, some axillary. And the cardiac sarcoid is another problem in United States, granulomatous, systemic disease, but affecting heart, either making heart block or ventricular tachycardia, sometimes clinically silent. And now using either perfusion defect, but FTG fills the defect by inflammatory, particularly this macrophage cells. As MR also use a non-specific delayed contrast enhancement. That's usually related to fibrotic process. Early fibrosis is quite a vascular. Late fibrosis is no vascular. And so, but in PET, you can see all functional myocardium, and so it's combining two together. Certainly makes a but the better evaluation. But the MR basically show sort of end result, anatomical path showing more functional aspect. So sarcoid also takes up a sort of a neuroendocrine somatostatin receptor, and so certain FTG uptake area shows DOTA NAC or DOTA Tate, small cell. Ulcerative colitis, so intensely increased activity in the intestinal tract. You have to first rule out metformin, which is diabetic medication. If patient takes up this one, then there is an increased metabolic process in the liver of glucose, so that the metabolite comes out into intestinal tract. So you have intensity. But in this case, the patient did not have metformin treatment, so this ulcerative colitis very intense. So indium 111 leukocyte will show the same thing. Indium leukocyte is leaking, but this FTG is taken up by macrophage in the inflammatory wall. And this immunoglobulin 4 also has been tested, and autoimmune pancreatitis, lymphadenitis. It shows multiple lymphadenopathy. It's autoimmune disease. And the aortic graft infection is also a common clinical problem. Any graft infection is always a major problem. It's not healing well by antibiotics, eventually reoperated. So showing wall infected wall precisely is important for surgeons. Spinal chronic osteomyelitis show very intense increased activity in with this FTG. So accuracy is all good by all agents. Three-phase bone scan even good, but non-specific. Gallium is also fairly good. Indium all good, but as I said, MR is highly sensitive but non-specific. And the acute process usually leukocyte good, but the three-way bone scan is just a screening things. And then FTG is very good. And stenotomy infected lines. So MRCT has some difficulty with this metallic artifactual string things. The FTG show very intense, infected. And spinal certain Harrington's rod, all that time, infected one is a major problem. All this FTG show very well. And certainly disc joint, knee joint, infected one show FTG, very useful, easy to showing. And certain cellularitis, diffusionist cellularitis, arthritic things is joint, so easily demonstrated by this gallium scan. And certain nucleoside septic arthritis, it's not easy to diagnose by conventional MR, CT, or nuclear bone scan. And this kind of nucleoside directly looking maybe DNA synthesis of this inflammatory process. It's easy to show. So hip or knee prosthesis has been popular, and infection is a major problem in about 10 to 20%. It's less with a better sort of prosthesis, but still infection, and that's FTG show some leukocyte only acute infection show. Certainly interpreting this leukocyte things, marrow scan with sulfur colloid is a helpful things, but FTG is easy, particularly with the SPECT system. So this FTG all show uptake around the infected prosthesis. And the leukocyte is generally show very acute because of increased granulocytes accumulation. Okay, this Thales osteomyelitis, particularly neurotropic arthropathy, together with this, it's not easy to diagnose. But this one is very confirmed, very nice. There's delineation of infected thallus bone, thallus or calcaneus more like. Great toe, three-phase, bone scan, increase blood flow, and the delayed or show, and it's a common problem after trauma. And certain proximal phalangeal osteomyelitis, MR shows some edema, cellulitis here, and some, and then so much intense uptake of FTG. It's proven osteomyelitis. And then certainly this plantar cellulitis, as well as a thallus bone infection. And then the scaphoid is sort of a necrotic, and then it's a bone here. Now using a SPECT CT, we can delineate bone and joint very clearly. And some here a little blurring, but the metacarpal section is uptake here. So this one is rheumatoid arthritic, sort of a non-specific autoimmune inflammation here, delineating inflammatory. So there's labeled the anti, as I said, technetium or F8 and ciprofloxacin has been mostly used. Other has been reported in the literature, but not been used much. Mechanisms directly bind to the certain RNA for the protein synthesis, certain drugs disrupting synthesis of layer structure bacterial cell wall, basically. Some kanamycin also prevent translation of RNA to make a proteins. So those are different little mechanisms, and then labeled with technetium. And then these were all reported in the literature, but not been used in the clinical environment. Again, FDA approval, that's one of major problem for small company. And also, we are not maybe convincing our colleagues in infectious division in the medicine or surgeons. So we have to maybe educate more internist surgeons for this kind of specific infection imagings available in your department. And so this kind of, or is either at least FTG or now bacteriophages using viruses. And very specific targeting, specific and superior imaging makes a difference. In old days, we didn't use a hybrid technique. So localization was a major problem. But now with the SPECT-CT or SPEC-MRI, we can precisely locate the active inflammation. And then by looking, we can estimate the burden of inflammatory or infectious process. And so labeling specific antibiotic, we should continue labeling new antibiotics, how they work, how much they work in certain individual patients. And then we have to label bacteria enzymes. So this directly hit usually bacteria, and then it's enzymes, and then also marker cell surface markers. So bacteria-specific imaging is certainly important in differentiate a lot of things. And so this certain antibodies, antibiotics, and metabolic substrate, and enzyme, and then bacteriophages have been tested. And the limitation as a signal to noisy is not that great. And then certain antibiotics unable to cross blood-brain barrier in brain inflammation or abscess. And then whenever we use any isotope, you have to think about half-life. So this kind of process requires sometimes serial imaging. So 6-hour half-life may not be sure long enough to evaluate the biological, particularly small lesion or inactive lesion. So metabolite is useful, and there's certain lots of metabolite we can think about. And there has been listed so many. So this has been all in the literature, so many agents, but none of agents has been used clinically nowadays. Particularly this kind of maltodextrin, maltose are very promising to separate infection from inflammation. But somehow this was developed by the somewhat chemical engineers, and but we don't use that. I think we have to keep this working on this kind of things. So this one is E. coli myositis. They label the maltose metabolite. And so maltodextrin for bacterial imaging has been proposed. And then they claim they can separate infection from inflammation in animal model. And the infection chemistry and the separation, infection, quantification by utilizing micropathings. And some antibiotic resistant, so they can evaluate by using this maltodextrose. And they also, there was a report of also a staphylococcus infection imaging by this F18 labeled trimethoprim, and then or this animal study. So and then this thiomaltose is also strictly targeting sort of antibiotics, and this also relate to some oxygen species with this hydroxyzide 7. So any disease with this reduced oxygen species is well known And so by utilizing this label, I can detect this hypoxia related to inflammation. All this one has been reported. Myositis utilizing C11 methionine protein synthesis also showed. So it's non-specific. This another sort of a agent they reported in the myositis specific inflammation. So virus specific imaging utilizing a protease, mostly RNA polymerase, and this kind of things. So this COVID virus, as I mentioned, needs some imaging. So at least we need the location precise. So the herpes simplex virus has been labeled with this nucleoside or DNA synthesis direct. Cytomegalovirus has been also. And so this has some application because it directly relates to cell proliferation, infection, and also maybe further therapy, and involving not only neurological disease or myocardial disorders. And directly it goes into the nucleus for synthesis. So it shows an animal with intense uptake with the herpes simplex. Remdesivir is a similar, chemically similar to all this nucleoside agent, has been used mainly for its brain imaging, and all acyclovir also has been labeled, all this antiviral. And so it's meningitis or something in the animal study only. Okay, and this antibody attached to CD4 effector T cell. It shows a very intense this liver sort of spleen. There's some activity here, and in the this bone marrow show this animal study, but this bone marrow human study show very this HIV infected here. And then gallium-68 isotope labeled with the marker of inflammatory in transplant, and shows inflammation in the sort of renal cortical parenchyma tissue. So inflammation in transplant kidney is also a major problem. It shows certainly MR show ADC map show decreased signals opposite to diffusion imaging, and that show matching with the specific inflammatory marker CXCR4. So there's no question this has to be replaced. And the idiopathic pulmonary fibrosis, that's another unknown disease, and it's a fibrotic strain or strand here, and diffuse infiltration. And that show this kind of a specific antibody attached to M1, macrophage M1, this one, and shows more specific inflammatory chronic inflammation. So lung fibrosis is all this bleomycin and other things makes a fibrotic. And micro CT has been shown. And now we have a agent, and that has been also labeled with gallium-68 F18, even rotation 177 for theranostic purpose. So rotation, right? So we are hoping this fibroblast active peptide. That's now 46 type. That's the best. And we are hoping to use this one in clinics very soon. That's the best for diagnosing cancer as well as inflammation and also therapy. The colitis has been shown with the acoustic imaging. That's colorful things. So multispectral acoustic tomography show, and certain bioluminescent and certain fluorescent show also things. So that's also in animal salmonella infection. So all this bioluminescent signal is easy to detect things, and the green fluorescent protein that's accumulated in the cancer or infection. But this one in bioluminescence is usually related to certain enzyme activity enzymes in the disease process. So CNS infection has been also shown in animal by utilizing bioluminescent. And so they probably use certain agent to attach to the enzyme. I don't know which one. And so they also show infection in the arthroplasty, knee joint things by utilizing bioluminescent. And all these things has to be moved to the clinics, but they, because of FDA control or some reason, it's still in the literature, mostly in the animal studies. So that's a problem. So we have to continuously push things. And then finally, there's lots of probiotics in the gut, as I mentioned, transient or permanent things. And we have to manipulate this microbiome, all these things. And so how they work, how much, those things are unknown. So utilizing, and then bacterial phage, using virus, killing bacteria. And it's also new, it's theoretically all animals show, but no one knows. So we have to learn a lot more. And then you have to realize that infection is so important, just like a blood clot. It's all related to many other diseases. So you have to continuously work on this one. Nuclear medicine is the best to understand the pathophysiology, the whole body pathology. The pathologists also look at a certain localized area, but this phenomena is our systemic. Inflammation, cancer, all infections are systemic, although it started with the local, but it's affecting whole body system, immune system. So we have to learn all these things. And if anyone of you make a better diagnosis, better treatment, or understanding better the mechanism of drug and prediction of drug, well, then we can select the best patient for the maximum efficacy. That's great in our clinical medicine. So I will stop here. If you have any urgent question, you can ask me now, but otherwise write down on the evaluation paper. And I thank you very much. I will talk to you about renal failure next week. Thank you very much. Please keep good health. That's most important than anything else.
Sir, may we have your comment on imaging using technetium-99m gluconate?
Technetium labeled glucomet. What is a glucomet?
Gluconate is like, it is developed by Professor Jiang Jaemin, and it is used for inflammation imaging?
Well, oh yeah, I should know more about that. And as I said, we've been using all non-specific agents. So if that is relate to pathogen, bacteria, virus directly, or the pathogen's metabolite, or certain immune cells, that should be more useful than currently available indium leukocyte or gallium 68, 67 citrate or F18 FDG. Those are all non-specific agents. So yeah, you should you know, publish more such a data in maybe pilot study. If you see the animals and humans are totally different environment when we introduce certain agent, pathogen, or some even cancer. So starting with the animal study, but it has to be tested in humans as a pilot study, And if they show, particularly separating infection from inflammation or infection from cancer, that's a great. That has to be tested. Yeah, I don't know much. I vaguely heard about that, but I never seen clearly the paper yet. So we have to find out more about that.
Thank you, sir.
Okay. Okay, if there's no other question, we'll adjourn the meeting today, and I will see you next week. Bye-bye.